Good morning, good afternoon, and good evening, depending on your location. We are all welcome to ISCH Post-Congress webinar. It is my great pleasure to introduce friend, colleague, and our well-wisher, Professor Amer Zeidan, one of the world leader in the field of hematological malignancy. He's a professor of medicine at Yale School of Medicine, and he holds multiple leadership positions at Yale Cancer Center, highlighted here. He also holds a number of leadership positions at the national and international level to help our patients globally. And most important to our patient and me is he led the many prospective clinical trial leads to approval of multiple drugs in the field. He's going to review today most important MDS studies presented at the ASH. Without further delay, Amer, floor is yours, sir.
Yeah, thank you so much, Dr. Savani, and it's a true pleasure to be here with you today. I'm always very happy to see all the continuous learning that comes from the International Academy of Clinical Hematology, and it's just amazing to see all the following that you have worldwide. So happy New Year to everybody. And what I'm going to be doing today is providing some updates from the American Society of Hematology meeting that just took place last month in December in San Diego. Of course, these meetings are always full of a lot of amazing abstracts, and it's always a challenge to try to select a few of them to highlight. So usually the way I like to do this is to put it in the context of what we currently know about the disease and how some of these abstracts fit in the classification, risk stratification, and management. So these are my disclosures, and I'm going to start with the classification updates and then go to low risk MDS and then high risk MDS in that order. So in terms of classification of MDS, this is an area that has seen significant evolution over the last few years. After many years of only doing the WHO classification, we had a new classification, the international classification or the international consensus classification. So now we have two classifications that are being used in the management of patients day to day. And while there's significant overlap, there are also important differences, and there could be some degree of disconnection in the diagnosis of patients. And this has led to some headaches, in all honesty, in explaining to patients the differences between the two, because both of them are being reported in the pathologic reports that the patients have access to, but also it's leading to some issues in terms of clinical trial enrollment, which classification do you use, and ultimately in terms of drug approval, etc. And part of the effort to try to harmonize these systems came through the International Consortium for MDS, the ICMDS, which has a representation really globally across the world from experts in the field. And this was presented last year, not this year, a project to try to harmonize the classification systems. I'm not going to go through this because it's already published, and this is a paper that came out of this. It came a few months ago in the Lancet Hematology. But I wanted to start with this because one of the presentations in ASH 2024 continued to build on the same theme in terms of how do we get a more unified approach to classification of myeloid malignancies, because one of the most important aspects of all of these classifications is the increasing reliance on genetic rather than morphologic and phenotypic presentations by themselves. And in this, I think, very exciting international effort called the Titan study, which was presented by Dr. Lanino and was on behalf of a collaboration between several groups, as you can see here, the Genomed for All, the Synthema, the EuroBloodNet, and the International Consortium for MDS. This effort involved more than 100 hospitals that contributed more than 20,000 patients with different myeloid malignancies, including AML, MDS, and MDS-MPN overlap, and MPNs. And some of them had matched RNA sequencing data. And also, I think was very interesting in this approach is explainable AI was used to try to derive a comprehensive classification that does not limit itself to one disease entity like MDS or AML, but try to understand on a spectrum how can we use genomic data to inform the classification schema. So this was a complex presentation, but I wanted to highlight the approach that was used in this, using hierarchical importance of genomic data to determine disease entities. And 34 clusters actually have been identified using this process. For example, having SF3B1 mutation primarily happens in MDS, but you can see that in MDS-MPN overlap as well as AML. And you can think of this as a genetic entity that has early disease in the form of MDS, absence of high-risk features, and no excess blast, that can go all the way to overlap and acute myeloid leukemia as it advances to more higher risk or advanced stages when you have addition of excess blast as well as certain high-risk mutations. So I think this is very exciting because it could open the door also for therapies that are targeted for the specific genetic alteration rather than the disease phenotype. So you don't, for example, as an example, if you are going to use luspatercept, which is currently approved in lower risk MDS, but you have a patient with MDS MPN overlap who have an SF3B1 mutation and primarily anemic, that could also be an option. But of course, we need the clinical trials to support that. So this study is still ongoing. It's still building up. And the goal actually is to try to involve as much data as possible from across the world to kind of make it very informed. And there will be a subsequent part to this where there will be a design and execution of survey of experts to address the aspects that cannot be addressed through evidence-based data generation. So for those of you who are specialized in myeloid malignancies worldwide and interested in joining this effort, this is the email you can email me at, and we'll be happy to involve you in this survey part of this project. Now, I think another important presentation in ASH focused on the same idea of these myeloid malignancies occurring on a spectrum. So we currently still have what we call CCAS, clonal cytopenia of undetermined significance. And the main difference of this versus lower risk MDS is having significant cytopenia that is not attributed to an external factor, and having a mutation that is known to be associated with myeloid diseases, but without having enough dysplasia on the bone marrow to call this MDS. And there has been, I think, an increasing interest in trying to remove that barrier between, because dysplasia is very difficult sometimes to read based on the expertise of the pathologist. And there is a lot of lack of consistency between different pathologists when they read dysplasia. So in this important presentation by Dr. Zoher Z from Moffitt, they looked at high-risk CCAS versus lower-risk MDS, and they used the prospective registry supported by the NHLBI, as well as the Moffitt Cancer Center cohort to look at patient characteristics and have a central review of the pathology using a combination of prospective data and centralized pathology to ensure consistent findings. And again, it's a busy presentation, but the most important point of this presentation is that patients who had high-risk CCAS, which is defined by two scores, you can see them here, already published, both of them, the CHRS and the CCRS. Using either of those scores, when you have high-risk CCAS, which is presented in blue bars, they significantly overlap in the progression-free survival with the lower-risk MDS, which is presented in red curves. And again, that's suggesting that the natural history and the prognosis of those patients significantly overlap, which again could open the therapeutic opportunity of treating those patients the same way you use low-risk MDS treatments rather than having to do separate phase 3 studies on those patients. So now moving from the classification updates to the therapeutic updates, And as you know, MDS for many years has not seen development of new therapies. However, in the last few years, we finally broke this deadlock and we have several drugs approved. We have an oral version of decitabine, sidazolidine. We have luspatercept. We have ivosidenib, which is an IDH1 inhibitor. And most recently, we have imetelstat. So 4 drugs have been approved in MDS in the last few years. And the treatment paradigm for MDS based on these developments in the US, where these drugs are available, has really evolved. So historically, the primary treatment for lower risk MDS in patients who have anemia as the primary problem used erythropoiesis stimulating agents. However, based on the COMMANDS trial, which was published last year, and I'm going to show you some of this data, luspatercept became the frontline agent in anemic patients with lower risk MDS if they do not have deletion 5q. Of course, if they have deletion 5q, lenalidomide continues to be the primary targeted treatment. And the second update in 2024 was the approval of imetelstat, which is a first-in-class drug that inhibits the enzyme telomerase and leads to improvement in anemia as a second-line agent. So I'm going to start with some of the highlights that focused on lower risk MDS, and then I'm going to go to higher risk MDS. So as background, luspatercept, as I mentioned, has been approved almost 5 years now. In 2020, it was initially approved. Luspatercept is a transforming growth factor ligand trap. What it does is that this pathway, which is increased in activity in patients with MDS and leads to suppression of erythropoiesis, this ligand trap, which has an activin receptor domain attached to an IgG-Fc domain and removes the ligands of this pathway from the circulation, leading to reversal of anemia, and has been already approved in the second-line setting based on the Medalist trial, and subsequently last year was approved in the frontline setting after the COMMANDS trial, which was the first trial ever to show a drug outperforming ESA in the frontline setting of patients with lower risk MDS who were anemic and need transfusions. And you can see here the comparison, which was 1-to-1 luspatercept versus ipotin. Of course, this trial has been now presented and published in Lancet and Lancet Hematology, but the primary results indicated a significantly higher chance of transfusion independence, almost double the transfusion independence rate of 60% compared to 30%, which was consistent across the subgroups, with the exception of the patients without ring sideroblast. However, what was presented in ASH this year in an oral presentation by Dr. Garcia Manero and colleagues involved in the trial was a long-term follow-up from this trial. And this focused on showing the durability of the response to luspatercept in some of those patients. So in this update, where was almost 2 years of follow-up on patients who have received luspatercept, for patients who achieved the primary endpoint, which was transfusion independence at 12 weeks, around 60 of them continued to be transfusion independent for 1 year, and around 40% continued to be transfusion independent for 1.5 years. And the median cumulative duration of transfusion independence was almost 155 weeks, which was significantly better than the 90 weeks with ipotin alpha, supporting that this drug is an important option that leads to durability of response in many patients. And when we try to look within the context of this abstract at predictors of long responders, or what we call super responders who achieve durable responses, I think some of the factors you would expect came up, such as having a low EPO level less than 200, patients who had SF3B mutation, and patients who have RS positivity. All of them had a higher chance of being long-term responders. But what was, I think, impressive is even in RS negative patients, there was a significant number of those patients who also achieved durability of transfusion independence, as you can see in this slide. And I think this study clearly supports the placement of luspatercept as a frontline option for anemic patients with lower risk MDS. And there were no concerns safety-wise in terms of new side effects, or increase in progression to high-risk MDS or AML. Of course, once you have a very good drug, such as luspatercept, get approved, which is safe and effective, the next step is trying to combine this drug with other active agents. And another presentation in ASH 2024 took an attempt to answer the question of combining ESA and luspatercept, but this was in the second-line setting after ESA failure. And the results of this, what was presented in ASH, was the dose-finding part of this study, which is called the COMPOLA study, and it was conducted by the GFM group from France. And you can see here the dose levels. There was an escalation of both luspatercept and EPO. So those were patients with lower risk MDS who did not have deletion 5q, and importantly, they did not have ring sideroblast. Those were ring sideroblast negative patients after ESA failure. And the luspatercept was given with the EPO, luspatercept every 21 days, and the EPO alpha was given in every week. And what was seen, I'm going to just give you the top-line results from this part of the study, is that there was an activity in around 30% of patients, 1/3 achieved erythroid responses. And I think the most important part, again, is that this combination was feasible. So you're able to combine these drugs without dose-limiting toxicities or severe toxicity. And that led to the initiation of the most exciting part of the study, which will look after ESA failure to compare luspatercept by itself, which would be the standard of care, versus luspatercept being added to ESA in a randomized 1-to-1 fashion trial that will include more than 100 patients. And I think this will be important to inform practice these days, and hopefully we can see results from this trial in the near future. In addition to the combination of therapies, another important idea has been the use of earlier step in the natural disease course for MDS. So the ELEMENT trial is looking at using luspatercept, similar to the COMMANDS design, luspatercept versus ESA, but before the patient is transfusion dependent. So those are patients who have lower risk MDS who are transfusion independent, but they have symptomatic anemia with a hemoglobin of less than 9.5. And the idea is to try to prevent them from becoming transfusion dependent. So this is an ongoing study that is, I think, also will provide very important results in the near future. Now, Imetelstat, I already mentioned to you that this was approved last year in June in the US, is currently being under consideration for approval in Europe as well. And in this, in the Amer study, Imetelstat, which is a first-in-class telomerase inhibitor that is given intravenously every 4 weeks, and has been shown to be active in for anemia management after ESA failure based on the Amer study, which was a randomized phase 3 trial that randomized in 2-to-1 fashion patients to receive Imetelstat versus placebo. And in this trial, which was blinded and took place in more than in 17 countries, very large international study. In this trial, compared to the Middle East trial, the patients were not required to be RS positive, so you could be RS positive or RS negative, and the patient had a significant transfusion burden. You had to require more than 4 units of blood every 8 weeks to go on this study, and the median transfusion burden was 6 units per 8 weeks. So this trial is already published last year, the primary results in the Lancet journal, and most important data was the high rate of transfusion independence, which was 40% compared to 15%, which was also durable with a median duration in the second-line setting of around 50 weeks. So what was presented in ASH 2024 was an update, not only from the phase 3, but also from a phase 2 part of the study, as well as new data from a QTC sub-study of the phase 3, with the idea of trying to understand several important questions. The first question was, in the primary analysis of the IMerge, only 7 patients out of 120 patients had received luspatercept. And there was an open question, what is the activity of imetelstat after luspatercept, since luspatercept now is used as a first-line agent. And I think as well as other agents, what is the activity of imetelstat after hypomethylating agents, after lenalidomide, because all of those patients were excluded from the original phase 3 trial. So the first, I think, finding from this trial is that there was activity of imetelstat in patients who had received other treatment, including non-ESA type of therapies. For example, prior luspatercept, the activity rate, as you can see in this analysis, based on transfusion independence or IWG 2018 or 2006 criteria, there was around 30% response rate according to the transfusion independence. So the drug is certainly active, and it could be considered as an option right after luspatercept failure. And similar data has been generated after receiving hypomethylating agents, although it was not as significant as post-luspatercept, as well as after lenalidomide. So certainly, while the drug is primarily approved after ESA failure, it seems to be a reasonable option after luspatercept, after lenalidomide or HMAs. And I think the next setup of studies will look at combinations and kind of how does the best sequencing for patients will play out. So now that we finished lower risk MDS, I'm going to move to higher risk MDS. So in higher risk MDS, this treatment paradigm I'm going to show you here really has not changed in any significant way over the last 20 years. Hypomethylating agents continue to be the standard of care in patients who cannot go to transplant. But transplant is the only way to cure these patients, and we always think about transplant. But because they are older, they have comorbidities, many patients cannot proceed to transplant. The main update in the last year was the approval of the first drug after HMA failure, which was ivosidenib, an IDH1 inhibitor, which is an effective drug. But the problem is IDH1 mutations occur in only less than 5% of MDS patients. So it's not a frequent mutation, but certainly worth checking for, because the drug is certainly active in those patients who have the mutation. And despite having HMAs available for many, many years now, almost 20 years, and many trials that have been trying to build on HMAs by adding another drug doublet, many of those trials have shown nice data in phase 1 and phase 2, but once you go to randomized phase 2 or randomized phase 3, they have been increasingly negative. And I continue to need to update this slide every few months, unfortunately, with a new phase 3 trial. Last year has seen the failure of magrolimab and sabatolimab, although again, there's still some ongoing efforts to try to fully understand these phase 3 results. But we had this drought of drugs approved outside of the oral version of decitabine, which is decitabine sidazoridine, which is now available for our patients. So unfortunately, there have not been major breakthroughs this year to report from ASH in high-risk MDS, but there were important abstracts to report on. One of them came from China, which was a randomized phase 2 trial of decitabine plus minus atra in high-risk MDS. So this is a trial that enrolled prospectively in an open-label fashion patients who have high-risk MDS who were adults to receive decitabine versus decitabine with atra. And the trial was big. As you can see, it enrolled more than 220 patients. 110 of them received the combo, and 113 received decitabine alone. And what was important, actually, is that the CR rate appeared higher with the combination, with a 23% CR with the combo versus 12% with decitabine, with a p-value of 0.04. And the overall response rate was also better. However, that did not translate into improvement into the median overall survival, which was not statistically significant, with a OS of 23 versus 19 months and PFS of 15 versus 10.5. Both of them trended in favor of the combination, but they were not statistically significant. However, I would note here that a phase 3 trial has been reported in press release combining tamibarotene, which is, many people think of it as a super atra, and also ARARA super agonist, and that phase 3 was negative for the CR. So it's not clear to me how this data will kind of move forward. I think we need to have a bigger study, but it's not clear that this study will move forward. I personally would not recommend using this combination outside of clinical trials at this point. Now, as I mentioned, ivosidenib has been approved based on a subset from the pivotal trial that led to the approval in AML. This was only an 18-patient subset, but the responses were impressive, very durable, with a response rate around 40% after HMA failure. And many of those patients had durable survival and transfusion independence. So based on these data, the FDA has approved ivosidenib, and it's available now for our patients. And what was presented in ASH was an update on the second IDH1 inhibitor that's approved in the US for AML, not for MDS. And this was also from the same trial that led to the approval of olutasidenib after HMA failure. Olutasidenib in AML. And you can see here the dose escalation and the dose expansion. This is an oral drug, as you can see here, and the primary endpoint looked at CR rates and safety. And you can see here the activity for those patients, both with the olutasidenib by itself and in combination. So there were responses, as you can see here, and the survival also looked good, but it's a single-arm study with a relatively small number of patients, but certainly with a CR rate of 20% and with the combination of around 36%. It seems this is a reasonable option. So to my eye, it doesn't look much different than ivosidenib, and I think it's reasonable to try to use it, similar to ivosidenib in MDS with IDH1 mutation, although it doesn't have a label for it. But with either drug, it's important to monitor for differentiation syndrome the same way you do for acute myeloid leukemia. And there was another update, which I think was also an important one, looking at the IDH2 inhibitor, enasidenib, which is also approved in the US for AML with IDH2 mutation. This mutation is slightly more common in MDS and AML than IDH1, but still relatively rare. Less than 10% of patients will have IDH2 mutation. This drug does not have a label in the US for MDS, but it does have a label for AML. And this trial, called the IDEAL trial, came from France, from the GFM group. And it included several cohorts, including HMA failure as well as frontline and lower risk MDS, and used the same approved dose of enasidenib, which is 100 milligram every day, with a primary overall response rate as the primary endpoint. And again, you can see here that there is activity after HMA failure. There's activity with the combination. And the safety profile looked good. Generally, some differentiation syndrome, which was manageable, but no significant high risk or high grade SAEs and AEs. So I think this is a reasonable option in patients who have an IDH2 mutation after HMA failure. So I certainly encourage you to look for mutations and consider these drugs for patients with MDS. Additional trials are looking at IDH1 and IDH2 inhibition in MDS. And lastly, I'm providing an update about response criteria, because this has been also an evolving subject in MDS. As I mentioned to you, many failures of trials looking at high-risk MDS, and I think part of that failure was related to use response criteria that did not reflect clinically meaningful benefits. So in an effort to overcome the problems with the 2006 response criteria, a large group has come together in the International Working Group to update MDS response criteria from across the world. And this update was done in 2023, published in Blood, for those of you who are interested to read the full paper. And these criteria have started to be used in several clinical trials and being reported. And there was a presentation in ASH that wanted to look at several questions regarding the response criteria and its association with benefit from transplant. And here I like to remind you again that you should always consider transplant for patients. We have high-level biologic assignment data suggesting that up to the age of 75, that transplant can double the survival at 3 years, 50% compared to 23%. And it continues to be, I think, underused and sometimes under, the patient would be in their late 60s, and some of the community doctors think they are too old for transplant, which is no longer the case in the US, and I believe in many parts in Europe. Those patients, if they are otherwise in good shape and they have donors, they should be considered for transplant. So in this presentation, on behalf of the International Consortium for MDS by Dr. Rolls, the idea was to look at the interaction between the response rate and the transplant in terms of understanding the outcome of those patients. So what we know is that the baseline risk, according to the IPSS and the IPSSM, affects the risk. We know that the treatment response historically affects the risk. And we know that, of course, receiving allotransplant is better in terms of the survival. So in this analysis, the interaction of these three factors were put together using a very large consortium called the Validate that includes centers from multiple countries, as you can see in this map. And the coordination was done at Yale Cancer Center. So the first finding is that the International Working Group 2023 criteria did predict for survival. So patients who achieved a composite CR have a better survival than those patients who did not have responses, which was very reassuring. But importantly, patients who also had allotransplant has much better survival than those patients who did not have transplant, which is not surprising. But you can see that transplant already is looking like the most important factor in making survival a possibility for those patients. What was interesting, actually, is that in non-transplanted patients, achieving a CR, composite CR, certainly associated with better outcomes. But in patients who underwent transplant, on the other hand, it didn't seem that achieving a CR was necessary to achieve the response. And this is important because sometimes, our transplant colleagues or our doctors will not send the patient to transplant unless they have less than 5% plus. And sometimes people get quite dogmatic on, having less than 5% plus. And I think this data argue that you don't necessarily need to achieve less than 5% plus to achieve a response. And I don't think patients should be denied the opportunity, especially in a younger patient who potentially can receive myeloablative conditioning. Of course, this is retrospective, not randomized, but I think, again, it adds to the literature that maybe a full response is not needed in the context in a patient who's going to transplant. And I think the other important feature that came out of this is that the time to transplant is very important. Patients who go to transplant early in their disease course do better than the ones who go at later time, which is not the optimal time. So again, think of transplant, think of it early on in terms of patients who are otherwise fit for it and eligible for it, and make sure you work with your transplant center to consider every patient for transplant, even if they do not achieve a complete response for HMAs. So those are the conclusions, which basically highlight the main points I mentioned. So I'm not going to go through them in detail. In my last couple of slides, I'm going to highlight some abstracts that I'm not going to show slides from, but I think were important. There were two abstracts on oral hypomethylating agents. We know that in the US, Aztec 727, which is an oral formulation of decitabine combined with sidazolidine, is already approved for high-risk MDS. And the idea is that the Sidazoridine will inhibit the enzyme cytidine deaminase, which will allow the absorption of the cytidine, and therefore it can be taken orally. And based on the ascertained phase 3 trial, this drug was approved in the US. Two presentations in ASH looked at patients who had TB53 specifically with oral decitabine, and those patients appeared in propensity score matching to have better results than patients who have received IV decitabine. But I think we need to really understand this data better in terms of like the selectivity for TB53. And there was another presentation on another oral formulation, but with azacitidine called Aztec 030. And this drug also has shown activity in the early parts of this trial, and now is being studied in a phase 3 setting for MDS. So this could also open the door for another oral hypomethylating agent option for MDS. Venetoclax, as we know, is approved in patients with AML who are unfit for intensive chemotherapy. There is data in the second line and the front line management in MDS. But of course, the most important trial is the Verona trial, which is the randomized phase 3 trial comparing Ven with AZA versus AZA with placebo. This trial accrued more than 500 patients and still not reported. So we are hoping to hear about this in this year. And this, again, could be a major change in the landscape of management of MDS if this trial is positive. But there were some presentations on venetoclax use retrospectively with azacitidine, and again supported the idea that many of those patients do achieve responses. So I think many of us are very anxious to see the results of the Verona trial. And I would conclude that there were a number of other agents that were presented in phase 1 data in MDS, both lower risk as well as higher risk. There was a presentation on a drug called DFV, which is an inflammasome inhibitor. There was not much responses there, but the patients were late in their therapy, and there were some cytokine changes. So there is an ongoing effort to try to study the drug earlier in the disease course. And there was also presentations in second-in-class transforming growth factor inhibitors, and I think the field is certainly kind of seeing more development with IRAK inhibitors and other drugs for MDS, and we're hoping we will have more options for our patients in the near future. So this was my last slide, and happy to take any questions.
Thank you. Thank you so much, Professor Zeidan. So those who did not attend ASH, this is your place shopping center, one place shopping center for MDS review of ASH meeting. So we do have several questions, and I'll start with the way I received in order, some similar questions I have merged together. So the questions are divided into low-risk MDS and high-risk MDS. So let's start with low-risk MDS. Again, thank you for detailed review of all low-risk and high-risk MDS. So what is your approach in low-risk MDS with anemia, transfusion dependent, in RS negative? What do you use first? What is your preference?
Yeah, this is a very good question. So I'm a strong believer in taking the data from randomized trials as they were done. I would not personally use the subgroup analysis from the COMMANDS trial, which showed that patients who were RS negative did not have the same degree of benefit to kind of say that you are going to go with ESA first and then get luspatercept. That has been my initial approach, to use luspatercept in the frontline setting regardless of RS positivity. And the data that was presented in ASH, I think, were also very important to support this approach by showing that those patients have more durability with luspatercept compared to ESA. And I think also in terms of some of the patients who achieve longer than 1.5 years of transfusion independency, I ultimately think the best approach is to combine them rather than keep debating which one to use them. But of course, we need additional data. The French data, I think, were encouraging about the combination in the second-line setting. But I do think we need combination in the front-line setting to kind of do this in a scientific way. There is some retrospective data suggesting that the combination is active.
So we have several questions on second-line therapy, low-risk MDS transfusion impact. So those patients who had prior ESA, what is your first choice?
Yeah, so I still would go with luspatercept after ESA failure. It's relatively easy to give. The side effect profile is easy, and I think the biggest or the most kind of challenging subset after ESA failure are the patients who have very high EPO level. Those patients or the patients who have very heavy transfusion needs. I think in those patients, I would consider trying Imetelstat, but my general approach in general is to go with luspatercept first, especially in patients who are RS positive.
And then those patients who had prior luspa failure, what is your choice nowadays? We have the agent.
Yeah, so we had a specific abstract that addressed this question, which again was, I think, very kind of heavily anticipated because all of us were asking this question, and it seems like 30% of patients achieve transfusion independence after luspatercept. So I do think it's Imetelstat is my choice. For me, hypomethylating agents for lower risk MDS are the last line. So I would probably give Imetelstat first and then hypomethylating agents after that.
So two more questions on low risk MDS. The interesting question is, Professor Mott, is should we use luspa for patient in replacement of EPO?
You mean instead of
EPO,
I think that is primarily my approach in the frontline setting, and I think the data that was presented in ASH certainly support that.
So this is a little bit outside the MDS, but MPD type of question. Is luspa feasible in myelofibrosis with anemia?
Yeah, that's a good question. MPN is not my kind of area of expertise, but what I can tell you is that there is already phase 2 data suggesting activity of luspatercept, and there is ongoing phase 3 data. So I don't think I would recommend using it like right now without randomized, without approval. There's no approval or there is no phase 3 data, but certainly it seems the drug has activity there as well.
And this is again one more clinical question and critical question. When do you consider azacitidine or allotransplantation in refractory low-risk MDS transfusion dependent?
This is a good question. Azacitidine, as I mentioned, I tend to use it as the last line option in patients who have lower risk MDS. Now, again, lower risk MDS is, as we discussed, is an evolving definition. So for patients, for example, who are categorized as lower risk MDS, but the primary problem is neutropenia or thrombocytopenia, and those patients exist, hypomethylating agents would be early on because we don't have other drugs that help very well in that setting. However, I do think you have to think about transplant even in lower risk MDS, especially now that we have improved our technologies and we can control GVHD better, and even older patients can be transplanted safely. And what we know is that after ESA failure in transfusion-dependent patients, the median survival is 3 years, which is not great, right? If you are a relatively younger patient in your 60s and 3 years, now if the patient is, 75, 78, this is where I think you could debate, but I always take the age of the patient, even in lower risk MDS, in consideration, because ultimately, once you start failing agents, it's clear that you are going to look at transplant. So once you have ESA, luspa failure, and you start going to Imetelstat and HMAs, I certainly start considering transplant.
So, Professor Zeidan, we have a question coming in. So one more question again on low risk. Considering role of iron overloading transformation to MDS to AML, as demonstrated in animal models recently. Do you think the use of luspa as a first-line therapy could potentially mitigate the risk and provide beneficial effect of delaying disease progression?
Yeah, this is a great question because I think it goes to the idea of, are we looking at the right endpoints in management of patients with lower risk MDS? Currently, all the focus has been on transfusion independence, but we know most patients with MDS die from MDS with complications related to heart failure, and without progression to AML, really. So I don't think we are having, because it's a relatively rare cancer, we don't have like trials where you can include thousands of patients to look at things like overall survival. But my sense, and we already know that luspatercept has important activities on cardiac modulation as reflected by some of the biomarkers, like such as the level of BMP, as well as on the iron parameters, as you mentioned. But we still don't have randomized data to suggest that overall survival or progression-free survival is better. We have data that responder versus non-responder do better, but these kind of are always very tough to interpret statistically. But I agree. I think iron chelation in patients who are transfusion dependent is always a good idea, but the current drugs have some issues and it's not easy to tolerate. And I think the best way really to manage iron chelation is to make the patient transfusion independent with some of the active therapies we have.
So this question is on novel therapy. Do we have any drug in pipeline, TGF-beta superfamily ligand trapping, like elritercept? What is your perception?
Yeah, that's a good question. So this is one of the second-in-class agents after luspatercept. So this drug has been presented several times now as a single kind of line agent. In those analyses, it was not done after luspatercept. It was done after ESA, similar to the Imetelstat trial. And the drug is certainly active. It certainly seems to lead to transfusion independence. It certainly seems to based on some analyses that were presented in this ASH meeting, have improvement in quality of life. But all of these were like single arm studies, relatively small number of patients, although the trial is getting bigger. So I think the drug is certainly active. There is an ongoing phase 3 trial that is looking at it right now. Of course, the most important question is how does it compare to luspatercept? Is it active after luspatercept? But I do think it's a very good option. There was some hint that it might work better in patients who have heavier transfusion burden, or it might help some of the patients with thrombocytopenia, which is, by the way, something we saw with luspatercept as well, some improvement in the neutrophils and the platelets. So I think it's very tough to say that it's the better in-class drug. We need additional data, but certainly seems to be active clinically. And this could be, I think, a drug that could get approved in the next few years based on the phase 3 trial.
So we have still lots of questions on low risk, but because of time limitation, I'm going to switch gear to now high risk MDS. So this is a common question on low risk and high risk. So when patient is indicated for azacitidine, nowadays, do we need to switch to oral AZA in all patients, or there are certain indications where you use still IV azacitidine?
I tend to use oral HMA frequently whenever I can. The issue in the US is more about reimbursement. Sometimes the copay can be quite significant, but it's a much easier therapy to give for patients who are otherwise stable. So in patients who are in a complete response, especially if they're not going to transplant, and you are doing this as a kind of therapy for the rest of their life or until progression, it's not easy for patients to keep coming every month for 7 days to get the injection. We actually have patients who decide to stop therapy just because they don't want to continue coming 7 days, and they don't. Many of the MDS patients, are older. They don't have like family members who can drive them. Their friends can support them the first few months, but when this becomes like a lifelong commitment, they don't have someone to drive them back and forth, etc. So I think switching to oral HMA certainly is something I strongly consider. But the point I would like to emphasize is that just because you are giving the drug oral doesn't mean that you don't have cytopenia. You still have to monitor the patient. Those patients could have infections, neutropenia. You have to make sure they get prophylaxis if they are neutropenic and monitor their counts. But certainly from a patient perspective, it's better. We actually have data from ASH. I didn't cover it today, but looking at what the concept called time toxicity. Patients with high-risk MDS who are going for transplant are effectively terminal patients, right? Because they are going to live around 2 years on average. And if you spend 30% of your time in a healthcare setting, whether coming to the infusion center to get transfused, that's a lot of your time that you are spending away from your family, from doing things you love. And people think, well, coming to azacitidine injection is 1 hour. I can tell you in my center, and I suspect in most other centers, you have to drive, you have to park, you have to wait for the blood work. This is usually really a full day affair for most patients. These are 7 days taken out of their life every month. So I strongly consider it when I can.
So, and this is in reference to now high risk, purely high risk MDS question. This is in reference to your slide on graveyard or HMA-based combination in high-risk MDS. So, we don't have any approved drug for past almost 2 decades, except as a site. I mean, talking about label, though we use off-label many things. When do we expect next combination? Because it's a combination era nowadays.
Yeah, I think the only randomized phase 3 trial that is, completed and close to reporting is Verona. I'm hoping we have results from Verona in 2025, and I look forward to getting rid of that slide of of the graveyard and having something that actually works. But I'm hoping we have results from Verona this year, and clearly excited to see a positive combination. So hopefully that will be it.
Do we have anything else in pipeline other than Verona trial?
Nothing in the phase 3 at this point. There are other second in class or best in class CD47 agents. For example, we have a drug right now called AK117, which is from China, that had a CR rate of around 50% with azacitidine, and it didn't lead to anemia. This is undergoing phase 2 data right now in the US. So we'll see what that shows, but this could go to a phase 3 depending on the results. We also have other immune checkpoint inhibitors. I didn't cover that, but we have an anti-Clever-1 a drug, bleximimab, basically, which is from a company called Faron, which is also showing nice data in the refractory, HMA refractory setting, and now is being looked at in the frontline setting. So I think there are drugs, but they are relatively in phase 1 and phase 2, nothing right now in the phase 3, to my knowledge.
And this is a final question. I'm sorry and thank you for your time again to answer.
Sure.
So final question, what is your approach in high-risk MDS for initial therapy? Those who are transplant eligible and those who are not transplant eligible patients.
Yeah, HMA, and I don't spend much time, in all honesty, thinking about AZA versus decitabine versus oral decitabine. In my mind, all of these drugs are equivalent. The most important thing is to actually treat the patient, because even in the US, a significant number of patients will not be treated. And the second important thing, as I emphasized, although I'm not a transplanter, but I strongly believe that those patients should go to transplant whenever possible. So I do discuss that early, even in patients who are in their 70s, if they are otherwise in reasonable shape. And the point I like to make, as I mentioned, is that I would move to transplant whenever we are ready. I would not delay transplant just because someone does not achieve a complete response, or at one point, people were not even transplanting patients because they have MRD persistence, which is very tough to clear MRD in MDS. So I think the data from the ICMDS validate database kind of helped, again, supporting the idea that I would not delay transplant just because you are stuck on a blast count of 5%. Of course, if there's something better you could give to the patient, you could, but currently we don't have anything that is better than going to transplant. except in situation where you have an IDH, mutation where you could try an IDH inhibitor. But, giving patient intensive chemo if they can, clinical trials, etc. But I think ultimately, whenever possible, try to go to transplant.
Professor Zeidan, thank you so much. Let me tell you one thing. All online participants are still there despite we are on upper end of time limit. Again, thank you for all your help, treating our patient, helping our patients, and your leadership. So on behalf of ISCH, we all thank you very much for listening. If you have any feedback, please let us know. And if you want to review presentation later, this presentation recorded webinar will be available on ISCH website. And we appreciate again for joining us today. Professor Moti is also here. Do you have any additional comment, Professor Moti?
I do apologize. I could not join you on time because I'm running in a busy clinic, but between two patients, I was listening carefully, and that was really amazing. Thank you so much, both of you, for enlightening us on this. Thank you very much.
Yeah, and it's a true pleasure always to join you, and very, very happy to see the growth on the IC, International Academy of Clinical Hematology, and your audience is always very engaged and asking great questions. So thank you so much for the invitation.
Wonderful. Thank you.
Thank you, Professor.
Bye-bye.